Hi, this is Dr. Weaver, the Child Health Team, and I wanted to put together a short PowerPoint presentation just discussing some of the key concepts that are kind of specific to safety related to pediatric inpatient experiences. However, I think you'll find that really any of these concepts can be applied to your adult patients or really patients of any age. So as you assume care of this child, you want to make sure that you have a recent weight within the last 24 hours because all of the medications, the weight is so critical in the pediatric population because all medications, IV fluids are going to be calculated based on weight. When I began my internship at Dallas Children's, when we would come on, we would look up all of our medications, make sure that take the original orders and make sure that everything had been transferred to the MAR, and also looking up your PRN medications. That way, if your child spiked a fever during the night or had a seizure and he maybe needed to give a PRN, clonazepam or Ativan, you knew already that that was an appropriate dose. Also, you're wanting to look for any pending diagnostics. Typically, this is well known, well documented, but I think this oftentimes was more of an issue, say, if you were admitting a child from the ER and maybe getting a verbal report. Sometimes you would get a patient up and get them settled and then recognize that they had been tested for pertussis. And maybe that had not been communicated in the handoff. And so you and others may be in there without the appropriate PPE. All right, once you have completed the chart review and have reviewed all of the diagnostics that are pending, you will identify what precautions are needed. Typically, if you're taking care of most infants and toddlers, oftentimes they are infectious or what we call dirty. So we would need to have the appropriate signage on the outside of the door. So anyone coming in is aware, dropping off a tray, a visitor, what have you, but everyone just needs to know what they need to do to protect themselves entering the room. And then I would also make sure that you have all of the appropriate equipment. And I would go ahead and stock all of that for the day. If you get there and you see you've got half a package of gowns, you know you're going to need gowns before your shift is over. Go ahead and get all of that stocked, and then that way you're ready to go. So once you have reviewed and identified any diagnostics that are pending or diagnostics that have come back positive, you will need to know the appropriate isolation precautions and want to make sure that that sign is clearly posted on the outside of the patient's room and that you have all of the appropriate isolation precautions, gowns, masks, gloves, whatever's appropriate for that patient, and just make sure that it's well stocked. That way you don't run out halfway through your shift. You just want to have everything ready to go. So once you have reviewed the chart and determined any diagnostics that are pending or any screenings that have come back positive for RSV, a viral illness, chickenpox, whatever, you will know what isolation precautions are appropriate. You'll want to make sure that you have a sign clearly displayed outside the room with an isolation cart that is stocked with all of the personal protective equipment that is needed. But you want to have this very clearly defined. That way, anyone coming into the room, say dietary or child life, can clearly see what equipment and what is needed in order to protect themselves and the other children in the hospital. Something else, so once we get inside the room, I want to make sure that all of the equipment that is needed is set up, ready to go. We have oxygen. I would have a nasal cannula, probably a simple face mask, an ambu bag that is set up, connected to O2 and ready to roll, as well as suction. You can see that on this image, they have a tonsil tip suction catheter. If you have an infant who's in with like a respiratory ailment, you'll also potentially have some like deep nasopharyngeal suctioning equipment as well. But I would pull that tonsil tip catheter off of that, turn my suction on, make sure I've got good suction, make sure my O2 is working. Just want to make sure everything is ready to go. You don't want to discover when a child is vomiting or if a child were to stop breathing that we don't have a working O2 set up in the room. All right, as you enter the room and are assuming care of the patient and introducing yourself, you'll want to make sure that every single patient has an ID band, and the parent or caregiver that is at the bedside also has a matching name band. You'll notice I have down here a pulse oximetry. All of the kiddos in the inpatient setting will be on some kind of monitoring, apnea, pulse oximetry. It's really important to, first of all, make sure that your alarms are on and have not been silenced. They are not doing what they are intended to do if they are on silence. You also want to make sure that the settings are appropriate for the patient's age. A lot of times you will turn these on and they will automatically default to adult settings, an adult heart rate, an adult pulse oximetry, an adult respiratory rate. So you just need to make sure that those are appropriate for your patient's age to prevent fatigue alarm. If it's constantly going off and it should not be, then nurses and family can kind of get numb to them and not really utilize them to their fullest potential. The other thing that you want to teach your patients or parents is that what could cause a false alarm. Oftentimes your pulse oximetry probe will come off. Just explain to the parent, you know, that happens, and always look at the baby. If the alarm is beeping, do not necessarily panic. Always look at the baby. If the baby is pink and smiling and kicking, they've probably kicked it off. That is very different than if you look and the baby is apneic or blue, then obviously we have reason for concern. But just kind of reassuring patients, parents will go a long way in reducing anxiety and really trying to help facilitate them participating in the care of the child. So once you enter the room and have verified the name band, your monitors, you're going to look at the child or the infant's IV site. And you'll see in this picture that there's like, we call that a doghouse. It's just this little plastic cover that kind of covers the IV insertion site. But we want to make sure that you can assess the tissue around the catheter, the vein along where that catheter is placed. You're wanting to look for redness, coolness, swelling, anything that might indicate that you have an infiltration or any kind of irritation or inflammation of that vein. And in the pediatric population, we will check that IV site once an hour. If you have an infant who has fluids running, it does not take a lot of fluid volume-wise to cause potentially significant damage. If you have an IV infiltration that is uncaught and has infused for an hour or two, you can have tissue damage, potentially need grafting of skin. So we just watch those very, very closely. The other thing you want to check is, of course, that your IV fluid rate is appropriate, that you have calculated it before you come in. What is the appropriate 24-hour fluid maintenance need for that child? And you've broken that down by the hour, and that the pump is set to the appropriate rate. The other thing you want to take a look at is your IV fluid. IV fluid, typically when a child comes into the emergency room, typically an infant or child will have D5.5 or D5.25 of normal saline hung. And once the child has voided, we've changed a wet diaper, then the order is added to include some potassium in that IV fluids. But 9 times out of 10, what is hung is fluid without the potassium, because we want to make sure that the child is voiding, that the kidneys are working adequately, and then the potassium is added. So it is not uncommon for a child to be transferred to the floor with IV fluid without the potassium. But once you have ensured a void, we know that the child is voiding without issue, that potassium needs to be hung. And typically you'll just get a new bag of fluid, and then you will change out the fluid. So you want to check the IV site once an hour. You're going to check your pump hourly as well. Typically what we will do is we will put in volume to be infused for like an hour, maybe 2, but that is kind of what is triggering you to go in and reset that fluid amount, assess that site, and then of course ensuring that the fluid is the appropriate fluid. Now, the last 2 slides talking about the name band, the monitors, the IV fluids, that's going to be for every single patient. Now, you're going to have patients with specific needs. So you'll see here that we have some padded side rails. So if you have a child who is on seizure precautions, you will need to cover the side rails to prevent injury. You'll already have O2 and suction set up and ready to go. If you have a child who has a trach, I've provided a little bit of sample here. This is what a typical PD trach looks like. You'll notice that it is not like the adult to where you have like the trach and then you just remove the inner cannula. The pediatric trach is a one-piece appliance, and this is changed out every 3 days. You have trach ties that are changed out typically once a shift and then as needed. If you have a child who has a trach, we would always have the size of trach that they currently have and then one size smaller inside their room. In the event that if the child were to decannulate and you were unable to get the current size, you would have the ability to place a one size smaller tracheostomy. Now, and typically what we would do is you would see those would just be taped to the crib. Now, taped to the crib, oftentimes in their boxes. I would open up those boxes. You can open that box and sometimes that trach had been used and that was just an empty box taped to the crib. You don't want to figure that out when the infant has decannulated or is having some kind of a plug and having an emergency. The next little image down here is a child in a basically like a little papoose kind of. And essentially we would have infants who would come in with severe reflux. They were typically admitted with an acute life-threatening event. Typically they would begin to reflux. Of course, the parents didn't know what was going on at that point, but they would come in because they had stopped breathing or had turned blue. So these infants, if they had been diagnosed with reflux, they would need to have their head of the bed elevated. And oftentimes that elevation was significant enough that we had to have almost like a little harness to keep them from scrunching down and kind of folding over onto the side. All right, something else that is very specific to the pediatric population you will want to provide toys for the patient. Of course, it needs to be age specific. This will be mitigated a little bit if they are not in isolation and have the ability to go to the playroom. But even so, oftentimes you're going to want things within the room. You're going to notice over here we have a bouncy seat, a mobile, music. These are very helpful if you have a young infant. Especially these bouncy seats, oftentimes if you have patients who were alone, you could wrap them up in a blanket and put them in that bouncy vibrating seat with some music, and that was quite helpful to calm and soothe the infant if you did not have someone to sit in the room and hold the baby. Over here you see we've got some toddler toys. So we have some push and pull toys, books, blocks, containers that they can put objects into. But again, just wanting to have things in the room that are age appropriate for your patient to play. Here we have some toys that are specific for the preschooler. You'll notice the dress-up toys, the big wheel, and then over on the right-hand side we have some collectible type baseball cards, simple board games, simple models, and just some different activities to entertain your preschooler and school-age child. All right, and here we have some not necessarily toys, but age-appropriate activities for the adolescent. Nonviolent video games, nonviolent music. Their big focus is probably going to be staying in touch with their peers, with their friends, maybe via FaceTime. But these are just some different activities. Depending on the hospital, at Cook's, we always had a few PlayStations that we would share between children and clean really good in between. But actually, when I left, they had built in like DVD players and PlayStations like into every room. So these are just some different activities that might be desired by your adolescent. So just to reiterate, we want to, your safety steps are going to begin before you ever get to your patient's room. You're going to be verifying weight, medication dosages, diagnostics. Then outside the room, we're going to verify that isolation precautions and supplies are apparent. And then inside the room, making sure that the patient has a name band, the guardian or the parent has a name band, that the monitors are not silenced, that the ranges for the different vital signs are appropriate and age-based. The IV fluids are correct, the rate is correct, and that we're checking that IV site once an hour for signs of infiltration or inflammation, and any kind of patient-specific precautions, if appropriate, are at the bedside, along with the O2 suction and ambu bag that will be at the bedside ready to go for all patients. And I didn't put on here, but of course, toys. The Child Health team hopes that you found this helpful. We hope that you have a great time in your simulation learning experiences this week, and you find this PowerPoint as well as all of the things that you will learn during your simulation helpful as you progress into the inpatient clinical setting. If you have any questions, please contact your clinical facilitator. Thank you.